Welcome to JCO Precision Oncology Article Insights. I'm your host, Dr. Jordan Goldstein from Stanford University. Today we'll be discussing the recent JCO PO article titled EXONERATE-TRaCE, a liquid biopsy for tracking response to anti-EGFR-based therapy in metastatic colorectal cancer, published by Takahashi and colleagues. A central problem in oncology today is that it tends to be reactive in nature. This is particularly the case for metastatic solid tumors. A patient gets a diagnosis of a stage 4 cancer, is started on a treatment that we hope will work, and is monitored until intolerable toxicity or cancer progression, often determined by growth on imaging or new symptoms. However, there are opportunities to move from this reactive approach to a more proactive strategy that dynamically monitors for evidence of resistance during treatment. And so this is the goal of the EXONERATE-TRaCE assay, which focuses particularly on anti-EGFR therapy in metastatic colorectal cancer. Advances in systemic therapy for metastatic colorectal cancer have significantly improved survival rates. However, it still remains a leading cause of cancer-related mortality worldwide. First-line therapy for colorectal cancer is now biomarker or sidedness-driven. For the 5% of tumors that have high microsatellite instability or deficient mismatch repair, immunotherapy is the preferred treatment. For patients who are KRAS, NRAS, and BRAF wild-type, preferred treatment is a doublet chemotherapy, including a fluoropyrimidine and platinum, combined with biologic agents that are based on the side of primary colon cancer. Left-sided tumors are known to benefit from the addition of anti-EGFR therapies such as cetuximab or panitumumab, which is what we will focus on in this paper. Anti-EGFR therapies are also known to be beneficial in BRAF mutated patients. While these therapies are contraindicated in KRAS or NRAS mutated patients and are rarely used in right-sided colon cancer. But even with already targeting anti-EGFR therapy to specific patients likely to benefit, responses are heterogeneous with response rates below 80% and a 12-month progression-free survival around 50%. This really highlights the need for better identification of patients who are likely to or will continue to benefit from treatment to better personalize care. So this is an opportunity for liquid biopsies, or blood-based detection of circulating cancer molecules, as a non-invasive way to monitor for resistance in real time. While most recent liquid biopsy research have focused on cell-free circulating tumor DNA, this study takes a different approach. The authors looked primarily at microRNAs, or miRNAs. MicroRNAs regulate gene expression by binding messenger RNA, or mRNA, and therefore can influence tumor biology and drug sensitivity. MicroRNAs can be detected in blood as circulating cell-free or as exosome-derived molecules, which offers a combination of sensitivity and tissue specificity that may be missed by single-site biopsies. By looking at both cell-free and exosome miRNAs, the authors previously developed the EXONERATE assay, which stands for Exosome and Cell-Free miRNAs of Anti-EGFR Resistance. The initial data for the EXONERATE assay was published in Clinical Cancer Research in 2025. This paper showed that the EXONERATE assay, by combining 8 cell-free miRNAs and 9 exosome miRNAs, can generate a risk score that accurately predicts response to anti-EGFR therapies at a pre-treatment time point with an AUC of 89%. As expected, EXONERATE risk scores were higher, meaning less likely to respond to anti-EGFR therapies in right-sided patients over left-sided patients. However, quite interestingly, the EXONERATE assay outperformed sidedness for predicting response to an anti-EGFR agent, identifying some right-sided patients who are likely to respond and some left-sided patients who are unlikely to respond, suggesting perhaps more utility as a predictive biomarker than just tumor sidedness alone. The authors in this JCO PO paper take this assay a step further to ask, can this pre-treatment response prediction assay be applied as a monitoring tool to predict the emergence of resistance? This is the basis for the EXONERATE-TRaCE assay, an optimized version of the EXONERATE assay for use in dynamic monitoring. The addition of TRaCE in the name stands for Tracking Response in Clinical Evolution. The authors use a single-center retrospective longitudinal cohort of 52 patients with RAS wild-type metastatic colorectal cancer who received first-line cetuximab or panitumumab between 2017 and 2023. A total of 142 serial plasma samples were assessed, 46 pre-treatment and 96 during treatment. They first ran their original EXONERATE assay, which used PCR to identify microRNAs. Validating their prior results, the EXONERATE risk scores were able to separate good and poor responders to anti-EGFR therapy before treatment with an AUROC of 89%. When the authors looked at longitudinal samples in patients predicted to respond poorly before treatment, those with initial high EXONERATE scores, the EXONERATE risk scores initially decline during treatment, suggesting disease response, but quickly rise again prior to disease progression. On the other side, for good responders, the EXONERATE scores start low and continue to be low during the first 18 months of treatment. What this suggests is that EXONERATE risk scores can be used as a dynamic marker of disease evolution under anti-EGFR therapy and chemotherapy, The EXONERATE panel was fairly large initially and cumbersome for longitudinal monitoring, so the author simplified it to make it more feasible using a backward stepwise elimination approach. This reduced the cell-free miRNAs to just 4 and the exosome miRNA panel to 5, all of which are related to EGFR signaling pathways like MAPK4, STAT1, or MAP2K1, or EGFR tyrosine kinase inhibitor drug resistance, like PDGFA or FGFR2. This now made up the optimized EXONERATE-TRaCE assay, which showed improved predictive accuracy for response to anti-EGFR therapy, with an AURC of 94%, particularly relative to current clinical tumor markers of CEA or CA19-9 with AURCs of 81% and 72% respectively. The EXONERATE-TRaCE assay shows rising risk scores between 6 months and 3 months before clinical progression, and continues to increase at the time of progression, suggesting that it captures disease evolution and has potential lead time of 3 to 6 months for predicting treatment resistance. Again, this ability to effectively monitor disease for anti-EGFR resistance was shown in both left and right-sided metastatic colon cancers, suggesting it can perform independent of primary tumor location, though it's worth noting there are only 8 right-sided tumors included in this cohort. To illustrate the benefits of the EXONERATE-TRaCE assay, the authors provide 2 vignettes with longitudinal data for EXONERATE-TRaCE and conventional tumor markers like CEA and CA19-9. The first is a patient with right-sided colon cancer with multiple liver metastases. 1 month in, the patient has a partial response. All 3 biomarkers decrease. However, by 9 months, the patient progresses. At that time, the EXONERATE-TRaCE score has increased substantially higher than even at initial diagnosis. However, both CEA and CA19-9 remain low. The second vignette is a patient with left-sided colon cancer with multiple lung metastases. At diagnosis, EXONERATE-TRaCE starts elevated, while CEA and CA19-9 were actually low. At 2 months, the patient had stable disease with no change in tumor markers. However, at 4 months, you see the EXONERATE-TRaCE risk score rise, while CA19-9 and CEA are unchanged. 2 months later, the patient progresses, with a continued rise in the EXONERATE-TRaCE score, but still no change in clinical tumor markers. These vignettes highlight that EXONERATE-TRaCE may have more value for detecting resistance and at an earlier time point than the standard tumor markers, and before clinical progression. However, it is worth noting that there are some limitations to the study. It's a retrospective, single-center study and therefore requires validation in a broader setting to ensure robustness and generalizability. It will need standardization under a CLIA-based framework for clinical use. And right now, we don't really have data that this earlier information regarding the development of resistance impacts how we treat patients and ultimately outcomes. We'll need further clinical studies to answer these questions. While the authors compare EXONERATE-TRaCE to standard tumor markers, circulating tumor DNA assays have become more commonly used in colorectal cancers. More information on how the use of ctDNA compares to EXONERATE-TRaCE, both as a pretreatment prognostic factor and for dynamic monitoring, is important to truly understand the benefit of this assay beyond tumor burden. As of today, metastatic colorectal cancer treatment relies on static pretreatment biomarkers, primarily in the form of specific mutations detected on biopsies that may be limited in comprehensive assessment due to intratumoral heterogeneity. Developing assays that can provide pretreatment efficacy prediction and dynamic resistance monitoring is essential to improve precision care. The streamlined EXONERATE-TRaCE assay shows the ability to use microRNAs to predict treatment resistance, not only before anti-EGFR therapies, but also dynamically through disease evolution for colorectal cancers. By capturing tumor-driven and treatment-related transcriptomic changes, it improves on the current standard for treatment decision-making, which often includes tumor-sidedness and conventional tumor markers. This has the potential to allow for more personalized, real-time treatment decision-making, moving from a reactive approach to a proactive one. This is an intriguing proof of concept for dynamic resistance monitoring, but much more work remains in adapting evolution-guided precision oncology into clinical practice. Thank you for joining me at JCO Precision Oncology Article Insights. Please subscribe and join us next time as we explore more groundbreaking research shaping the future of precision oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.